It's Butte, like yeah, like in Montana.
All right.
My dad actually came to the U.S. and started graduate school at UW, and realized that everybody in Washington knew how to pronounce Butte because Montana was just over the border. So
Right.
that's how we pronounce our name. But yeah, I'm happy to introduce myself. Yeah, thanks for inviting me, Len, and I really appreciate everyone coming out early. I know for us this is a little early for allergy and especially for some immunology. So I'm going to try to keep it fun, and I'm going to give you mostly talk about a case today. But my name is Manish Butte, so I'm the division chief for allergy and immunology at UCLA, and I mostly do immunodeficiencies, and I run a research lab where we work on T cells. So I'm very interested in how T cells fight infections and autoimmunity and cancer. And we use a lot of mouse models and also study human diseases as well. And prior to coming to UCLA, I was a junior faculty at Stanford for about 8 years before I got recruited down here. And then prior to that, I did my fellowship training at Boston Children's under Raif Jaha, and I did postdoc work after fellowship in Arlene Sharp's lab, where I worked on PD-1 and PD-L1. And prior to that, I was a resident in pediatrics at Children's Hospital of Philadelphia. So I've been on both coasts. And what I'm going to talk to you today about is a rare complication of a common infection. One that spreads actually up into Washington State. So maybe you'll get to see some of it over the course of some of your careers. But my desire is sort of to convey to everyone that we can learn something from even common infections when we're thinking about the underlying immune system. So I'll just jump right in. So disclosures wise, I'm going to talk about off-label use of interferon gamma and dupilumab. These are medicines that are FDA approved for other purposes, but we're going to repurpose them in the case here. And then I have some speaking and research contracts, and none of these are particularly relevant for today's talk. Okay, so I'm going to start by jumping into a question that comes up actually quite frequently when immunologists think about what does it mean to be immunodeficient. What should we get consulted for and what should we not get consulted for? And I like to think about it as the flip side of that is what does it mean to be immune competent? And I think this is sort of a little bit easier of a concept to put a finger on, even if it's a little bit non-specific. Immunocompetence, at least to me, means that you can recover from an infection with or without symptoms and come back to your homeostatic baseline without any particular treatment. That is, your immune system can field the ball and get it back to the pitcher without having there be any sort of adverse permanent disability. Okay, so a very simple corollary to this idea, though, is then anyone who dies of an infection must be immunodeficient, must not be immunocompetent. And I think that's sort of a simple way to start jumping into the question of then of sort of what drives immunodeficiency in humans. Because we tend to think of immunodeficiencies as very rare diseases. And what I'm going to pose to you is this idea that immunodeficiencies are not actually all that rare. But let's start by jumping into some of the numbers. Of the great killers of humanity, Plasmodium, which causes malaria, tuberculosis, influenza, et cetera. What we find when we dive into the numbers is that these infections actually are broadly infectious across the world, but only kill a small fraction of the people who actually get infected. Tuberculosis, for example, causes TB in about 10% of the cases, but the mortality rate is about 2%. Malaria, only a fraction of a percent die. We now know from many hundreds of millions of people who've been infected worldwide that SARS-CoV-2 only kills about 0.2% of those who are infected. This is, of course, broad numbers. Some populations, like the elderly, are going to be dying at 100 or 1,000 times the frequency, depending on comorbidities and other factors, and younger are going to be much less than this. Spanish flu, even, one of the great killers of the 20th century, killed about 3%. Staph, strep, candida, all the other things we get consulted on are even less. So why is it that some people are more susceptible to infection than others? Does it represent an immune deficiency? So one hypothesis that people make when they think about this inter-individual variability of infection susceptibility and outcomes is that it's an acquired defect, something that was brought on because of a state, for example, of malnourishment. This is commonly cited as a reason why people die in indigent populations. But malnourishment itself may be brought widespread, and even then, only a fraction of those populations, for example, may die of malaria. So this probably doesn't explain why some people do really well with malaria and some people don't. What about microbial variation? Yes, over time, we know, for example, influenza goes through shifts in the genome where there are some years that are especially bad, like 2009, and other years that are extremely mild, like 2014 or 2019. And then we know this from COVID as well. There are going to be some strains of microbes that are much more transmissible than others, or maybe more deadly than others. But not during a single outbreak can you really then explain why some people do really well and some people don't. So another commonly cited explanation is the level of inoculum, that if somebody directly sneezes on you or somebody directly infects you, you're more likely to get a severe outcome versus a lower inoculum might result in a lesser inoculum. This was tested inadvertently through the preparation of BCG vaccine, where Mycobacterium tuberculosis was actually loaded into vaccine vials, the pathogen itself, and injected into babies who were trying to get BCG vaccinated. And surprisingly, of 250 infants who got a very large inoculum of bacteria, still not all of them died. About a quarter of them died, and 3/4 of them didn't. So the conclusion you can draw from this is that it's unlikely to be an acquired defect, although certainly a level of inoculum is going to affect outcomes, and malnourishment will, and the acquired immune deficiencies that arise from malnourishment. And certainly some strains are going to hit some populations more than others, perhaps based on HLA types and other factors. So there's going to be, all of these are undoubtedly true to an extent, but they're unlikely to really explain the bigger picture. The other sort of conclusion is that when you think about the numbers shown in the previous slide and here, that the immune system is incredibly successful at keeping our species alive, that not all of us will survive all infections, but some of us will survive all infections. And in fact, most of us will survive all infections is a pretty good conclusion that you can draw from what our immune system offers us. And what really is shown, that point is particularly shown in this graph that I stole from an old paper from John Casanova, where he showed that in the prehistoric times, these curves down here, that about almost half the people were dead by the time they were 5 years old. And certainly the 50% line for mortality hit humans at around age 24. That was the median survival of humans in the prehistoric era, was 24 years old. That's what evolution had available to it. That's why most people have had all their children by the time they were 24 years old in prehistoric times. You might actually start to become a grandmother by the time you're in your late 20s if you survive that long. And we really have stopped seeing this idea that most humans are susceptible to infection and fatal infections throughout their limited life because of factors like clean air and clean water, hygiene, vaccines, et cetera, which tremendously boosted survival in the early years to the point where we now think that if anyone gets an infection in their first few years of life, or in their first decade of life, or in their first 40, 50 years of life, that is life-threatening or lethal, that it must represent some sort of genetic anomaly. But the reality is that we're all born with this very significant immune deficiency. We've just managed to clean it up, which is to say that even common pathogens in our environment used to be lethal to us. We are predisposed to dying of an infection. We're not really protected from all kinds of infections. Our immune system isn't the pinnacle of evolutionary optimization. It isn't even close. We can die of anything. Half of us were dead by the time we were in our mid-20s. And so again, the point here is that we will survive as a species. Our immune system allows our species to survive, even if individuals actually were dying off. So what explains the heterogeneity of infection outcomes is genetics. So twin studies, for example, for tuberculosis have shown that monozygotic twins who are identical twins have a much higher concordance rate of tuberculosis than dizygotic twins. These statistics bear out for multiple types of infections studies carried out over many years. And in the late 80s, a group in Scandinavia published a very interesting study where they showed that twins who were adopted to two different households, sorry, not twins, babies who are adopted to a different household, and that baby's tracked for whether they die of cancer or natural causes or infection. And then you ask the parents what they died of. The susceptibility of the child dying from infection being inherited from the biological parents was 5-fold higher than the probability of any other cause, cancer, natural causes, age, natural aging, et cetera. So this supported this idea that even though the child is adopted to a different household, a different set of epigenetic circumstances, for example, that there's still an inherited risk of dying of infection that is undeniable. So we used to think about primary immunodeficiency as like targeting these patients up at the tail end, the upper end of severity and opportunistic infections and unusual infections and bad infections. And we've tried to convince our colleagues in infectious diseases to stop calling this bad luck. This is not bad luck. There's some inborn error. But the reality is that we're not just thinking about these highly penetrant, severe cases, not just opportunistic infections. In fact, all infection susceptibility is genetic. It represents a failure of our evolution to provide us with protection to these infections. Remember, anyone who gets an infection and dies of it is likely to have some degree of immunodeficiency. Whether these immunodeficiencies are rare and need a consult and need genome sequencing, et cetera, as we do for our patients, or whether we should stick to this idea that this is the bad luck, that the cards that humans have been dealt at this point, that's up to you to decide. But I'm going to walk you through a case of a relatively common infection and how we still were able to learn something very interesting from it. Are there any questions at this point in the talk? Anybody have any comments? I have one more slide that sort of captures this idea of a common infection, common genetic causes or rare genetic causes. This again was taken from Casanova paper just from a few months ago, where he proposed this idea that primary infections that occur with life-threatening consequences in early life are likely to be single genetic variants, monogenic, pathogenic causes of immunodeficiency. Whereas those people who die later in life from infections, typically maybe having a reactivation infection, this could be like EBV or zoster, although those are rarely lethal. But genetically, these are probably not rare point defects that lead to a particular susceptibility to infection because of some non-redundant part of the immune system, but instead represent this sort of polygenic predisposition that is part of being human. That we all have some susceptibility to infection, especially as you get on in life. Now, where these lines occur, he's drawing this line here of puberty. Certainly, that puts a lot of people dying in their 20s and 30s, which fits in with that sort of evolutionary model that I showed you earlier. In general, though, we recommend, regardless, at least consult immunology anytime that there is a life-threatening infection, any severe infection, anybody, regardless of age. And we have found in some of our old patients monogenic disorders that are super interesting. Telomere deficiencies in 60-year-olds, NF-kappa B deficiency in 50-year-olds that really help explain some of the more interesting complications that some of these patients face and never got worked up until they came to immunology. Why do I talk about genetic testing and genetics as being the basis of a lot of these immune diseases? Because it's now quite feasible to do genetic testing. First genome sequence was over $1 billion. Now we're doing it. It takes about 2 weeks, and we charge about $700. We are charged about $700 for a research genome. Clinical genomes are about double that, about $1,500 at this point on the open market for clinical. It's all made possible because of instruments that have changed the throughput of sequencing. This is the Illumina Nova Seq6000. This is what really brought sequencing to below the $1,000 genome now 4 or 5 years ago. These puppies are about $1 million each. Not going to be buying one of these for your garage, but certainly UW has a number of these, and UCLA has a number of these, and it's what makes low-cost sequencing possible. It makes it possible to sequence every patient that we see now. And we should be sequencing every patient. There are many countries now, the UK and Canada, for example, where they have now made it part of the government-funded healthcare system to sequence all patients with rare diseases. We know that most rare diseases, like primary immunodeficiencies, have a genetic basis, and patients with genetic diseases deserve genetic diagnoses. We should be testing all of them. Why? Because it gives them relief. It gives them the end of their diagnostic odyssey. Many of our patients, especially the older ones in their 40s and 50s and 60s, have been bouncing around from hematologist to rheumatologist to gastroenterologist for years with unnecessary testing, treatments. Some of our patients are put on steroids for half a decade, just hoping for the best without having any real answers as to the underlying immune defect. Many of the treatments now are expensive, and you need an ACE card to be able to play against the payers, the Anthem Blue Crosses in the world that are eager to not pay for anything. And to give them an ACE card, you need to be able to say, here's a genetic diagnosis. Oftentimes they'll yield at that point. Targeted treatments are now very common. I'm going to show you some off-label targeted treatments in a few minutes. But we use JAK inhibitors, we use monoclonal antibodies left and right in immunology now, targeting specific pathways that show either gain of function or aberrant activity in an attempt to do something that we call rational-based medicine, try to suppress certain parts of the immune pathways to try to bring homeostatic baselines back to normal. And of course, gene therapies are not clinically available yet in the United States, but are expected to be incredibly expensive, hundreds of thousands, if not $1 million per. That's certainly the case for some of the gene therapies that are used for muscular genetic diseases at this point. And they require genetic testing to be able to really pay for. And of course, family planning. A lot of our patients are really not eager to bring another child with skin into this world. So we offer them things like pre-implantation genetic diagnosis, to be able to have in vitro fertilization and have a baby without having SCID. That's true for other genetic diseases as well. And so the second major take-home point here is to pursue genetic testing for all patients with primary immunodeficiencies. They deserve a genetic diagnosis. Okay, I'm going to jump into the case unless there's any questions at this point. I don't see anything in the chat box. Nobody's unmuting. Okay, I'm going to jump in then. This is a case of a 4-year-old boy. You can see the back of his neck here in February 2018, so almost 4 years ago. It's hard to believe. He started with this very itchy and painful rash on the back of his neck. And within about 2 weeks or 3 weeks, these lumps and very painful and tender lumps appeared on his forehead. He had 3 of them, one on the side here and two in the front. They were very, very tender, and his mom took him to a local emergency room where he was transferred to UCLA. We got a biopsy, and the biopsy showed this very characteristic fungal spherule that was surrounded by a multinucleated giant cell here. You can see this is a characteristic lesion for a disease called Coccidiotomycosis, also called valley fever. Coccidiotomycosis was first discovered by a surgeon and pathologist and pediatrician named Alejandro Posadas, who lived in Argentina in the late 1800s. And being a well-trained pathologist, he had one of the first microscopes and staining techniques to be able to find fungus in tissues. And in fact, he found in a lesion on the face of a Uruguayan soldier, this lesion here, you can see, this is the very first patient ever to be described with coccidiotomycosis, a soldier named Domingo Escura. And he biopsied that and found fungus and thought that he had explained a fungal cause for a skin cancer called mycosis fungoides. Instead, what he described was, of course, the fungus that causes cocci. So Domingo Escura went on to die, and his infection spread. It spread to his hands and feet. You can see his hands and feet are captured in this display at the University of Buenos Aires. And you can see that he had this lesion, fungating lesion here on his hands. And then, of course, it showed you his face. It was all over his back as well. And Posadas became famous. In fact, the species of cocci is one of the 2 species is called Posadasii as a tribute to Dr. Posadas and his work. So cocci itself is not, of course, confined to South America. It's confined to a big stripe of the United States in the Southwest US. I'm going to show you all the way down to Argentina. And the cases wax and wane, and they're not rare. These are thousands, if not 10,000 cases a year. In 2020, we had 6,000 cases because of COVID. In 2021, also a lower number of cases than expected because of COVID. But these number of cases are the reported ones. We think that there are 2 or 3 times as many cases of valley fever than the ones that actually get reported to the public health system. Of these 10,000 or so cases, about 200 go on to what's called disseminated cocci. And the costs of disseminated coccidiotomycosis in California are huge. Each one of these cases costs about $1 million in direct costs and $500,000 of indirect costs per year. So this is an extraordinarily expensive disease for our state. We spend $300 million on these cases, these 200 cases of cocci a year, and we spend another $700 million a year in California on the other 10,000 cases of non-disseminated cocci. So close to $1 billion a year our state is spending on this infection. So this infection, of course, is not just in California, but also occurs in much of lower Arizona and then New Mexico and West Texas. It extends into southern Utah and Nevada. And then there are cases actually in eastern Washington. The soils themselves are contaminated all the way from Washington through this strip of the United States into Mexico and all the way down into Argentina in the southern hemisphere. And that's because this landmass was aligned in a way where all of this land got seeded with this fungal species millions of years ago. In California, the cases are confined to this Central Valley where there's a lot of agriculture and development going on. And Kern County, which is right next to LA County, this is LA County right here. This is LA County right here. Kern County has the highest incidence, about 0.3% of all people in Kern County get valley fever every year. This is not a super rare disease. And as I mentioned, or as I'll mention more about half the cases are totally asymptomatic. Patients don't even know they have it. We know this from military surveys. There's a number of military bases in the Central Valley, and especially in Kern County, and in Riverside County, where 29 Palms bases and Edwards Air Force Base. There's a number of bases in this area where military studies have shown that people who are highly attracted in the military healthcare system can become cocci serologically positive without ever knowing that they had the infection. Yes, it's about half of those patients go on to having that. Curiously similar numbers to COVID. At least half the patients who get COVID have no idea that they had it. There are about a third of the people beyond that have a protracted and self-limited fungal infection of the lungs called valley fever. Many of them cure themselves. They get a cough for about a month, their cough goes away and they're done. They may end up with some residual nodular disease afterwards. This is super common in Arizona and California to have nodules in patients after an unexplained cough. And this is called valley fever. Many of these patients do need a short course of fluconazole to get them over the hump. And in fact, about 1/3 of community-acquired pneumonias in Arizona are thought to be valley fever and not bacterial pneumonias. A few patients go on to having a progressive pneumonia where it doesn't ever go away from the lungs. And then less than 1% of these patients go on to having what's called disseminated cocci. That's the very expensive dissemination that I showed you that Domingo Escura first showed us in his own case in the late 1800s. We thought of disseminated cocci as being largely a risk factor for patients who have an defect in immune competence. For example, in patients who are under immunosuppression treatment for transplantation or cancer, patients with HIV who have untreated HIV, for example, in the past. Pregnancy is a skewing of T-cell suppression in order to tolerate the alloantigens of the fetus, and is a particularly well-known risk factor. About a third of the patients who get cocci in their third trimester go on to having disseminated disease, and about a third of them die So this is a major risk factor. But there are other risk factors that we know less about. Males seem to be more affected than females. African Americans, according to the literature, are more susceptible to disseminated cocci than others. Some of this might be due to exposure. If you think about who works in the Central Valley, it's an agricultural intensive area, which tends to be male dominated for workers in the fields. And certainly there are a lot of African Americans and Filipinos, I didn't mention on here, are also thought to be a higher risk factor who happen to have jobs and working in agriculture. And then there are primary immunodeficiency cases. There are about 8 of these cases in the literature that were collected by Steve Holland's group now 4 or 5 years ago. And these are the 8 cases here. They're all younger adults or children who developed severe disseminated cocci. And interestingly, you can group them based on patients who have defective type 1 immunity. So in the bottom half here, boxed in red, defects in the interferon gamma receptor and IL-12 receptor, or in STAT1 gain of function. These patients all had extensive disease at both soft tissue and also throughout the skin, soft tissue, and organs. And then there are 2 cases here that have excessive type 2 immunity. So not defective type 1, but excessive type 2. And these 2 patients had hyper IgE syndrome due to loss of function in STAT3. And both of these cases had meningitis as their phenotype. Interestingly, if you talk to doctors who take care of a lot of cocci, they will tell you that soft tissue cocci and meningitis cocci are actually very different things, that they have a different trajectory, different kinetics, a different age, a different susceptibility in their minds. Infectious disease doctors will tell you this. And it's just curious that the 2 cases of this here had meningitis, and these all had soft tissue or bony disease. Anyway, why excessive type 2 immunity? Why defective type 1 immunity as a cause for cocci? I'm going to walk you through what I think is our explanation, but it's been known for a long time, since the 1980s. In fact, a group published that patients who have excessive IgE, total IgE, cocci-specific IgE, or even just eosinophilia, have a much higher risk of extrapulmonary disease, disseminated disease in multiple organs, versus those who end up with inactive disease, so common valley fever or pulmonary-only disease. So why type 2 immunity? Well, type 2 immunity skews, of course, is skewed by T cells in response to cues to tell the T cells that there is a non-fungal pathogen around, perhaps a parasite or something. And I can take some questions if people are interested in what drives that T cell response. But the type 2 cytokines made by T cells will skew macrophages over to what's called M2, sort of a broad phenotype that includes a variety of transcriptional programs that are not built for fighting fungus. So instead of having nitric oxide and killing capability, a lot of these M2 macrophages instead produce collagens and TGF-beta and are able to help clear debris, phagocytose, and have anti-inflammatory properties. Really not what you want to wire up as you're trying to fight a devastating disseminated infection. Okay, back to our case. So our 4-year-old had got a PET scan upon admission. What we found were lesions on his scalp. You can see here very extensive on his sternum, on his ribs, on his clavicle, and his wrists, and his tibia. And this is actually one of the areas that were lit up on the PET scan. You can see it's a little bit wider than the contralateral side. In March, and a few weeks later, this is what burst through the skin. Extraordinarily painful, highly destructive fungus that eats bones and soft tissue for breakfast. This area has to be surgically removed. Many patients need amputations. We were able to spare him an amputation and have our surgeons remove these lesions. He had multiple surgical stays, surgical visits in order to clear these infections all over. You can see the lesion in his clavicle was very destructive of the bone and in the brain too. It was penetrating, although it did not penetrate into his CSF space, it was eating into his skull. The one in the vertebrae in his back spread and spread and eventually collapsed one of his vertebral bodies so that he had some scoliosis afterwards. So based on Steve Holland's case, we decided to look at signaling through the interferon gamma receptor, and we stimulated whole blood with interferon gamma and interferon alpha, and then looked after 20, 60, and 120 minutes for phosphorylation of STAT1 downstream of the interferon gamma receptor. And just like in a control patient, we found that this boy had really fantastic phosphorylation and normal dephosphorylation of STAT1 in a normal time course. This suggested, again, sig defect in interferon gamma receptor. We did the same thing for IL-12 receptor, and by signaling through IL-12, again, Steve Holland's cases provided some guidance in this area. And what we found, surprisingly, was a defect. That when we stimulated with IL-12, waited 20 minutes, and then looked for phosphorylation of STAT4, we found only a small percentage of his cells were actually able to produce, were able to activate the IL-12 receptor and phosphorylate STAT4 as compared to a healthy control. So this gave us a very important hint, because IL-12 is needed to take healthy helper T cells that are undifferentiated and give them the cue they need to turn on the transcription factor T bed and become Th1. Th1 T cells make interferon gamma, and interferon gamma drives towards type 1 immunity and helps macrophages make all those interesting factors that they need to clear fungal infections and neutrophils as well. If he's not making enough IL-12, he shouldn't make enough Th1 cells, and what we should see is really like a 2-to-1 or 3-to-1 or even a 4-to-1 or 6-to-1, depending on your age, ratio of Th1 to Th2 cells. If you look in the population, across the populations at Th1 to Th2 ratios. So we thought to test this. If he has very low IL-12, he should have low Th1 cells. So we're going to examine that. And the way we do that is in vitro, culture the T cells with stimulation for a week, and then ask through flow cytometry to look for interferon gamma or IL-4. So IL-4 is on the vertical axis. This is Th2 T cells. This is Th1 T cells. And you can see here in our patient, he had about 4% of his T cells were Th1, and about 35% of his T cells were Th2. That is the opposite ratio. We wanted it to be 6-to-1, 8-to-1, 9-to-1 of this direction versus here, like you see in the healthy control here, a 2-to-1 ratio of Th1 to Th2. And instead, we see the wrong ratio. So this now supports this idea that our patient doesn't have enough IL-12 signaling and can't make Th1 cells as a result.
I ask you a question.
Really, yeah, please.
The tissue damage that you showed us, the necrotizing damage or bone lytic lesions, is that caused by proteolytic enzymes actually from the fungus itself, or is that tissue damage from the immune response?
It is a proteolytic from the fungus itself. So fungi themselves, I am not a fungologist, but I've gone to a number of Cocci talks now, and I was surprised to learn that the fungi that grow in your garden and in your yard have developed all kinds of fungi, all kinds of enzymes to break down cellulose. Cellulose is the main fiber that is the connective tissue for plants, and there's a whole suite of enzymes that plants that live on that fungi that live on plants make in order to eat plants, to debris, the dying, the decaying cells that are in your yard or in the forest are consumed by fungi. We all know that. There are other fungi that have lost those genes and instead have developed genes to digest animal tissue. So these are enzymes that break down our connective tissue, whether it's collagenases or proteases or metalloproteases that digest tissue. So interestingly, Cocci belongs to this family of fungi that have lost their ability to consume cellulose as a nutritional source and instead digest tissue. So yes, they are extraordinarily capable of eating tissue. Of course, when animals die in the forest, those also get decayed by bacteria and fungi. So this is the evolutionary mechanism for that. When we took this knowledge that the patient didn't make much Th1 cells, and we gave him, instead of just CD3, CD20 stimulation for a week, we also added in an IL-12. What we were able to see is that there was some rescue, although not much. He still had a 2-to-1 ratio of Th2 to Th1, but he was able to make some more Th1 cells. And this tells us that this defect in IL-12 signaling was not absolute, it was partial. And this was an important hint for us because it really gave us the crack in the foundation that we were able to use to find a treatment for him. But in the meantime, we realized that if he wasn't going to make enough Th1 himself, it required super physiological levels of IL-12 stimulation to get him to make Th1 cells and to make interferon gamma, that we should give him interferon gamma. And so we did. We took interferon gamma that was, of course, FDA approved for treatment and prevention in CGD. And we decided to dose him with this medicine, with interferon gamma. And we didn't really know what dose to pick. We picked the prophylaxis dose and we went up from there until he started having some side effects. And interestingly, we started to see an effect, at least in terms of his inflammation. His CRP was quite elevated. And after starting interferon gamma and titrating the dose a little bit, we were able to get his CRP down. We think that this is an important, this was also an important avenue for fighting this infection. But it wasn't enough. Even though he was getting interferon gamma, this is now 6 weeks into interferon gamma compared to at the start. You can see this lesion on the side of his head grew over that time, whereas the one in the front here, this one actually got surgically partially debrided, but it went away. And this one, which was pretty extensive and necrotic, also consolidated, but didn't entirely go away. And in fact, if we look in his bone scans throughout his body, we did not really get a win, despite now over a month of interferon gamma treatment at a very high dose. We were able to slow down the trajectory of the disease to a significant extent, though, but not enough. And this is, for example, the lesion on his skull. It sort of crusted and then cracked through and is extremely painful at this point. At this point, he couldn't, the pain was so severe from his limbs and from his skull that he wasn't able to eat, this little 4-year-old. So we had to put an NG tube in and feed him. And this was a very difficult time for him in the hospital. So we went back to our T cells to ask, we need more help, but we need to figure this out. And what we realized is that if he's making a lot of Th2 cells, and they're making a lot of IL-4, as you saw in the flow cytometry. Well, IL-4 actually blocks IL-12 signaling and may prevent differentiation of T cells to Th1. And so maybe if we could just block some IL-4, then whatever natural amount of IL-12 he's able to make will be able to allow some of his IL-12 signaling to come through. And so we realized right around this time that there was a new FDA-approved medicine for blocking IL-4 and IL-13 that was indicated for eczema, not for cocci. And but we thought, hey, this should physiologically work, and that's dupilumab. So it's an IL-4, IL-13 monoclonal antibody receptor blocker, and we tried it in vitro. We cracked open a dupilumab and we pipetted out some of it and put it in culture for a week. And what we saw was a tremendous rescue in our patient's Th1 cells, that we were able to bring his Th1 cells above the level of his Th2 cells for the first time. In healthy control, you can see that it significantly boosts Th1 cells at the expense of Th2 cell development. This is sort of an interesting idea now, that we can rescue his Th1s by blocking his Th2s. And so we started it. We tried it in vivo. He had already been on triple antifungals at this point. He had been really, our back was against the wall at this point. We did not have any other treatments available. And so we tried it. We didn't really know how to dose it. There's no dosing recommendations for 4-year-olds at that time. And so we picked a dose based on weights, and we gave him more and more until we found in vivo that if we treated his whole blood with IL-4, that we wouldn't see any signaling through the IL-4 receptor through phosphorylation of STAT6. At that point, we said, okay, this must be a good enough dose. His body can't even see IL-4 at this point. He must have good blockade of IL-4 receptor. And indeed, we saw a decrease in his Th2 cells and an increase in his Th1 cells after starting dupilumab. In fact, his Th1 to Th2 ratio went all the way up to 1.0 at full 50 weeks. Even over the next year, it rose up higher. But more importantly than his numbers, his lesions melted away. So he had this large epidural abscess of fungi here. You remember that vertebral body that was collapsed. This epidural abscess was devastatingly painful to him. And you can see here, just a few weeks into treatment with dupilumab, about 4 months into treatment with dupilumab, a repeat MRI showed that this abscess was completely gone. And in fact, all his lesions melted away. The ones on his skull melted away, including this large one in his temporal side. This is just the day after we started dupilumab. You can see he had this large painful lesion on his skull. This is a few weeks later, it crusted over and totally melted away on the other side. So we felt like this was a real win for us, this idea that we could take interferon gamma, and give him the factor that he's missing, and take dupilumab and push his T cells in his immune system away from type 2 immunity and towards type 1 immunity, and allow him to recover then using his own immune response. This idea of immunomodulation to treat infections surprisingly isn't something that people have done before. It has not really been mentioned in the literature. We weren't able to find any references to it actually in our, as we wrote up this paper, which some of you know, we published in the New England Journal now 2 summers ago. And it really, I think, represents this opportunity that we can take many patients with devastating fungal infections and offer them an ability to fix it themselves. So we actually,
question.
Yeah, please.
You didn't
Please,
mention TH17 and neutrophils. Do they?
Yeah.
What's their role in this infection, and why did you not consider them?
Yeah, I think I'm going to show a slide about TH17 in a second. Let me see here. I think I have a TH17 slide coming up. But I'll just tell you, yes, TH17 cells have been looked at in disseminated cocci to an extent by the vaccine folks. People trying to make a vaccine for cocci have come to the conclusion that you must elicit some TH17 cells to really get a protective response. That also bears out for patients with primary cocci, so not people trying to make vaccines, but people studying patients with cocci. A group at UC Merced led by Katrina Hoyer showed that in fact, it's not just the absolute number of TH17 cells or the proportion of TH17 cells, but the ratio of TH17 cells to Tregs that really is the important variable to determine whether there are enough TH17 cells or whether they're being suppressed by Tregs. Many of you know from these T cell drawings that TH17 and Tregs themselves share a common factor for driving their differentiation, which is TGF-beta. So both TH17 and Tregs, at least induced Tregs, require TGF-beta in the periphery to differentiate. Whereas in the presence of other inflammatory cytokines like IL-6, that you can make TH17 cells. If IL-6 levels drop down or are not adequate, then you may, with tissue, develop TGF-beta actually and end up producing too much Tregs at the expense of making not enough TH17 cells. So this ratio of TH17 to Tregs is natural. It's biological because they share a similar differentiation factor. And Katrina Hoyer's hypothesis is that if you make too many Tregs and expensive TH17 cells, perhaps because there's not enough IL-6 in the periphery to drive this conversion, that you'll end up also with a susceptibility to disseminated cocci. And we looked at TH17 too, and I'll show you that, as I said, in a minute. So we convinced Horizon Pharma to fund a small trial. It's going to be an open label trial with interferon gamma, where we're going to treat patients with disseminated cocci and monitor their skewing of T cells and their disease scores and see if we can actually get them to switch differentiation. And I'll show you why there's some biology around just giving gamma as a way of stimulating T cells to switching to Th1 as well. And we're working with Regeneron right now to do a similar trial with dupilumab, again, to treat patients with disseminated cocci and see if we can reduce their disease burden. But really the bigger picture is, can we apply this to many fungal, viral, bacterial infections that are all Th1 dependent? For example, we know the whole eastern half of the United States has blastomycosis and histoplasmosis. Histoplasmosis actually is in other parts of the world too, including Africa and South America. There's Coccidiotomycosis in South America. We don't have that in North America. There's sporotrichosis, which is which is highly endemic in parts of China and East Asia. Penicilliosis, another endemic fungal infection in Southeast Asia. So there are many such endemic infections, and all of them have in common a few percent of patients who go on to having disseminated and fatal disease. Blasto and histo, for example, a few percent of the patients with blasto and histo go on to having disseminated disease. Most patients don't. So there are going to be some opportunities across a lot of endemic fungal infections to simply repeat the strategy we used here. And we're encouraging folks to think and try this. Now, let's get back to the genetics because this is really important for our case. Our patient did not have a primary immune deficiency as his underlying defect. I'm going to just say that now. I don't still know that that's the case, but we did do both whole exome and genome sequencing, and we did not find any interesting pathogenic variants in any interesting genes, rare variants in any interesting genes. Of course, he had hundreds of thousands of variants in his genome sequencing, but we really couldn't attribute any of them to explain his IL-12 signaling defect or a primary immune deficiency of any other kind. Now, why? Why couldn't we figure this out? Partly because the way we do genetic testing today, the way you guys do it, the way we all do it, is we filter the variants that we find on exome sequencing by rareness. We only look at the rare ones. And that's because we have this mantra in our heads that rare diseases require rare variants, that if you have a common variant, it cannot cause a rare disease because lots of people should have it then. I think that mantra needs to be cautioned. We should use that mantra with some caution in the case of disseminated cocci, because in this case, the susceptibility to disease is simply enough. You have to also overlay that with an infection exposure. Now, as I showed you, about 0.3, 0.4% of all people in Kern County, California, are exposed and get infected with this every year. So there's quite a bit of exposure, but it's not universal. And certainly, if you live just one state away, like in Wyoming, there's no cases of cocci. If you live in Idaho or Montana, there's no cases of cocci. So even if you have a highly predisposing and not so rare variant, it's still not enough to actually contribute your risk to developing the infection. You have to actually have the infection as well. That idea was proven recently by Casanova's group, where they showed that a relatively common variant in TIC2 that affects the signaling of IL-23, and that is homozygously held by 1 in 600 Europeans. So the allele frequency is actually quite high. This 120 something people carry this allele, Europeans carry this allele. This contributes to susceptibility to tuberculosis. This is not at all a rare variant then. The allele frequency being a few percent of all people, 1%, 2%, something like that, of all people carry this variant. And yet it seems to contribute to tuberculosis susceptibility. So we have the same idea that maybe if we could just filter in a better way and take some of the more common variants that we are otherwise throwing away, ones that occur in 2% of all people, 3% of all people, ones that easily we would throw away in order to make exome and genome sequencing tractable, maybe our interesting variant in our child lies in that region. The problem is that we just don't have any tools for doing this. The more variants that you filter in, the more variants you filter in. And the number of variants you have to start thinking about rises into the thousands very quickly and tens of thousands very, very quickly. It becomes an incredibly intractable problem to analyze exomes and genomes unless you apply the rareness filter. And so we're sort of stuck. We don't really have good tools for thinking about this kind of genetic analysis yet. However, we did get a hint from RNA sequencing of our patient. We actually know that the IL-12 receptor comes in 2 splice forms, a long form and a short form, and they share these first. This is the first exon. This is on the reverse strand, so it looks backwards to us. This is exon 1, this is exon 2, exon 3. And here after exon 9, it either splices to a short isoform that stops here or a long isoform. And our patient made 94% of his transcripts into the short isoform. This probably, when we look at literature from Rich Robinson, he showed that the short isoform is not signaling competent because it lacks the transmembrane domain and the intracellular region that's needed to dock the JAKs and STATs and turn on signaling. So this isoform really is not competent to signal. If our patient's making the vast majority of his transcripts in the wrong isoform, then that could explain why he doesn't signal much through IL-12. More importantly, Robinson showed that if you activate T cells, especially through STAT1, interferon gamma drives STAT1, then you can actually switch the splicing from the short isoform to the long isoform. And in fact, it's important for you to know that all of us make the short isoform, and the average across 400 healthy controls is about 66% short isoform. So you and me make 2/3 of our transcripts as a short inactive isoform. And it's only upon getting Th1 cues like interferon gamma that we change our transcription to making more and more and more long isoform and being signaling competent. This is a positive feedback loop. And many of you who have studied immunology know that immunology is loaded with such positive feedback loops. Anyway, among individuals that we looked at, our patient was at the very top 1% of all patients with this short isoform defect. But with a year of treatment of interferon gamma and dupilumab, we actually rescued him. We brought his short isoform to 68%, right at the populational average, it turns out. And we also were able to rescue some of his IL-12 signaling as well. And we really think that this represents then a splicing defect rather than a fundamental defect in signaling. He was simply making the wrong signaling and competent form of IL-12 receptor. We don't know why. We're still trying to figure it out, but this may be a non-rare variant. And as I mentioned, we don't have any good tools for digging into that yet. So we're diving into more. We've done actually 80 genomes in RNA sequencing as patients with disseminated cocci and uncomplicated valley fever in collaboration with Hal Hoffman. We're starting to look at innate immune signaling in some of these patients, and with Morna Dorsey at UCSF, we're looking at some of the PID phenotypes and quality of life of these patients as well. Now, we did recapitulate the result that I mentioned that Katrina Hoyer showed. Our patients with disseminated cocci have lower Th17 cells. That's both by the chemokine receptor pattern and also by intracellular cytokine signaling, that they have less Th17 cells. And we were going to be pursuing this in our next set of experiments. We also found, as we looked at 70 or so individuals with disseminated cocci or uncomplicated valley fever, that about somewhere between 15 and 20% of them have an elevated Th2 to Th1 ratio like our patient. And so we think that about a quarter of the patients with disseminated cocci may benefit from a strategy that we employed here with interferon gamma and dupilumab. And so we're going to think about how to pursue that in our next set of grants and proposals. We're also we're keeping our eye on innate immune responses. We know that that signaling of chitin, breakdown of chitin, which is in the wall of a lot of fungi, and activation of innate immune receptors like dectin drives the Th2 biology that we see. This is an immune evasion strategy by cocci and other fungi to push the immune system away from type 1 immunity and try to promote fungal dissemination. And we think that some of the innate immune defects will be also something that will pick up on genetic testing and functional testing. So we have a lot to do to figure out why some patients with cocci infection go on to having bad outcomes, but we think we're on the right path in terms of looking at both adaptive and innate responses. So the work here was largely done by a project scientist in my lab, Tim Fallon, and a clinical fellow, Monica Tsai. And they're the first authors on the paper. And we were assisted by our Undiagnosed Diseases Network team that found the splicing defect, and by my clinical colleague and partner in crime, Maria Garcia-Loret, who was working with dupilumab at the time and thought of this idea that maybe we should employ this new medicine in this rare disease case. Thank you. I think I didn't leave much time for questions, but maybe 5 or 6 minutes.
Well, firstly, thank you for a brilliant presentation. As you think about these aberrant mechanisms and you think about other diseases like tuberculosis or leprosy that can take on either benign forms or disseminated forms, have you broadened this thinking to other infectious agents?
Yeah, well, we've definitely used interferon gamma in a variety of rescue situations. I think probably all of us have in situations where there's severe fungal infections. We and Don Vin and Steve Holland and others have published its use in a variety of cases, even outside of CGD. Yes, I think the idea of using dupilumab or immune modulation or immune skewing to treat infection hasn't been used before. I think our case was the first. And we have used it in other cases of disseminated cocci at this point. We have treated 2 other children with it, both who had excess Th2 cells, both who had pretty severe disseminated disease, and both who got better. We've now treated 3 more adults with it. This is all off trial, just rescue situations, patients who's dying of disseminated disease, and all 3 of them have done better as well. So we're sort of hopeful that this might be a way of a new treatment, a new paradigm of treatment. Instead of just pouring more antifungals on, as our infectious disease colleagues will say, this patient died of antibiotic deficiency or antifungal deficiency. Instead of thinking of that way, that we just need to add more antibiotics or antifungals to their lifestyle, maybe we should be skewing their immune system to the right state of being so that it can fight infections better for the host. I think that whole philosophy is sort of new in clinical infectious disease or immunology, and so we're still running with it as fast as we can. If you can think of cases that are occurring in your neck of the woods, we'd be happy to help you guys think about it and use it.
Well, what I really meant by that question is, do you have evidence in other common infections where the disease can either be relatively benign and self-limited by the patient, or becomes lethal, that you've already established evidence that there's aberrant Th1 or Th2 or Th17 pathways?
Yeah, we know that blast and histo probably share the same pattern, that they share the same kind of susceptibility to Th1, Th2 skewing, eosinophilia, high IgE levels, a history of atopy, certainly push blast and histo patients also towards severe outcomes. But whether those have been explored in the same way and the same depth as us is probably not the case. We talked to one of our colleagues at Vanderbilt who has started down some of these paths. In terms of non-tuberculous mycobacterial infections, again, a different family of infections. Similarly, there have been a number of groups that have looked at why NTB infections, which are mostly non-lethal in the elderly, can be quite lethal in a few. And again, there's this idea that Th1, Th2 skewing may contribute to that push to patients being able to control their infection or keep it at some sort of non-lethal lung level versus succumbing to it. So yeah, I think there is evidence across a handful of both fungi and bacteria that this might be a general pattern.
We have other questions out there. We got 40 relatively smart people listening to you.
Relatively smart, I like that.
Maybe not as smart as those of you in Southern California, but
I see my friend Karen is on. Hi, Karen. Hope you're well.
Karen, you asked about Karen. Karen's listening. I know that.
Actually, I do have a question about like the STAT3 mutation patients. Do you think this kind of treatment paradigm would help in those cases as well, when there's a more significant specific gene defect?
Yeah, that's a good question. People have already tried using dupilumab in treating the severe eczema of STAT3 loss of function and Job syndrome, and it's already had actually quite a benefit. I think it was an abstract in last year's Quad AI meeting or CIS meeting about using dupilumab in STAT3 in Job syndrome. So I think there is going to be some benefit there, even though it's a fixed genetic defect. Yeah.
There's a question in the chat box. I don't understand the question. Are there any changes in the virulence of coccidiotomycosis?
Changes over time?
I don't know.
Yeah.
That's the end of the question. That's all it says. Like,
Jen,
maybe
you unmute and ask.
Yeah, over time, has it become more virulent or something of that nature?
No, there's 2 species of cocci. They're clinically indistinguishable. They have different patterns in the soils of Arizona versus California versus elsewhere, and down in South America, but they're mostly clinically indistinguishable. The difference that you saw, those waxing and waning of incidence, is not due to changes in the species, but rather in drought. So when there's drought and people do agriculture or development, the soils get blown in dust storms, and those dust storms actually result in much higher incidence of cocci. And so there is some correlation to climate change. And in fact, there's a couple of groups now studying how drought and how climate change in general is going to change the pattern of cocci. There's a paper from, I think, funded by the CDC now looking at how cocci is likely to spread northwards across the western half of the United States all the way into southern Idaho and into Washington over the next 30 or so years as climate change and droughts in particular affect all of us. Yes, so wearing masks will help. Certainly this is a infection spread through the respiratory route, almost 99%. We do know of a number of cases of patients with primary cocci in the skin only, and it never disseminates in that case. They just have a lesion on their skin, and if it's biopsied, it's cocci. That has occurred. It's extremely rare. And I'm interested in that too, because I think there is some control of the infection, especially if it comes through the cutaneous route instead of through the lungs. But yes, the spores themselves are pretty large, considering the masks that we're all wearing nowadays. And so wearing your N95 will certainly help, especially if you're doing gardening work or if you work in agriculture or one important vector for a lot of patients in California is the prison system. Many of the prisons are located in the Central Valley of California, and as there's agriculture nearby and it blows through the prisons, that